I'll go
Okay,
ahead
so
and start. Hello, welcome everyone to our Parent Summer Camp series. Dr. Rice is presenting on Could Airway Issues Be Affecting Your Child? So please mute yourself. This video will be recorded, so if you do not want your image to be shared, please turn off your camera. Thank you again for being here today. We encourage you to type in your questions into the chat throughout the presentation, and we'll leave time for questions and answers at the end. My name is Amanda, and I have the privilege of working alongside Dr. Rice as her growth and outreach coordinator. Over the years, I've had the opportunity to meet hundreds of families who were searching for answers about their child's sleep, breathing, behavior, learning challenges, carotid teeth, and overall health. And that's why we're so excited to offer this educational event like this one today. Our goal is not to diagnose anyone or to tell you what your child needs. Instead, we want to provide information, answers, and answer your questions. So it is my pleasure to introduce to you Dr. Kellye Rice.
well, thank you so much,
And
Amanda. I appreciate that intro. I hope you were done there, right? So, okay.
yeah, I
So,
was going to say something else, but I'm going to let you take it away.
well, thank you. So welcome everyone. It's really an honor for us, for you to listen to what we have to say, for us to give us a chance to share our opportunity for what we see in our everyday practice, because we do meet so many parents, especially moms, who are searching for answers, and that's what is to be about. We want to connect the dots for parents who are searching for questions that they're not getting answered at their pediatrician or their pediatric dental offices, who they're getting excellent care already, but something's just not right with their child. So what we all want is health for ourselves and for our kids. But unfortunately, we're having to deal with disease, and so how can we make our children healthier, or when we don't ever have opportunity to get to the root cause? The root cause is really what we're talking about when it comes to breathing. By breathing, I mean nasal breathing, because our children are getting excellent care, but they are also being given medications all too quickly, sometimes for ADD, ADHD. Bedwetting's not talked about. Difficulty in school is kind of an embarrassment, but no child should ever snore. And this restless sleep that many of them are plagued with chronic allergies, is interrupting their ability to grow. And so we're here to talk about that. We know that this sleep disordered breathing, it doesn't have to be sleep apnea. It can just be a disorder of how they're breathing at night, or mouth breathing at night, is going to turn into full-blown sleep apnea by the time that they're adults if we don't do something about that. So what can we do? Well, we're dentists, and so we look at their craniofacial development and the development of their jaws, and if they can breathe out of their nose. Mouth breathing is just the beginning. It can be mouth breathing without snoring, and that still is a disorder of the correct breathing. And then when a child snores, we know that this should not be happening. That's an interruption of oxygen getting to their brain and development of that brain, that personality, and the rest of their body. Even in the Journal of Pediatrics, we know that oxidative stress in the whole body has been studied, and there are more markers that we are finding in children that have to do even with their heart health and their cardiovascular peripheral health. And so when we connect these dots in the research and carry it over into what we are doing in clinical practice, that's when health can really blossom. Dr. Karen Bonnock, years ago in 2012, did a study of thousands of children and found there's a strong connection between sleep breathing issues and a diminished IQ, also increasing the risk of ADD and ADHD by 50%. And so this is what we want to do now, is get the word out about that connection, not to make anybody wrong or any physician wrong by that, but just, hey, let's think outside the box a little bit here, because we know that our immune system gets impaired if we're not hydrated, if we don't eat well, if we don't breathe well, whether we're adults or kids, and it matters. Here's what we're looking for. we are looking for a 5-year-old where we can fit a nickel in between every one of their front teeth. These spaces are so important for proper width of the jaw and for proper room for that permanent tooth, which is going to be much larger, to come through. We make it really clear to our parents, this is not about beauty of the teeth. This is about foundation. Foundation so that they can breathe through their noses and make room, then secondarily for all of their teeth. And this is a 5-year-old in trouble where those lower teeth are hidden completely by the upper teeth. And along with this phenotype, the look of this bite in this 5-year-old, there were problems with bedwetting and crankiness in the morning, and her mom knew that she was not getting proper rest. And so here we are, after treating her with a growth guide, her sleep improved, and her bite corrected itself, and that maxilla and mandible, upper and lower jaw, are in a much better relationship with each other. So, and then cosmetically, yeah, the smile is not so gummy. The smile looks better, and anything that looks better in nature generally is functioning better. Why would we want to pull teeth when teeth are crowded? And so this is something that we're really passionate about, to help kids to not have to have teeth pulled as much. And there's a growing awareness of this. If we look at the arch form, we all are familiar with columns and arches, but we don't want this Gothic arch. And what we have found is that if the tongue is not acting properly to help grow the arch, then we're going to end up with not enough room for the teeth. We're going to end up with that high vaulted palate, that palate roof of the mouth that looks like it's farther away, as opposed to the picture on the right. And if that palate is farther away from us, guess where it's going? It's going right up into the nose. And there again is this jaw formation, nasal breathing correlation. Again, we say that the tongue is just the proper scaffolding when it's working right for the upper jaw. This gives us an example of what we shoot for, our target distance in millimeters between the two baby teeth on the bottom there. By age 4, we want to see 30 millimeters, along with the spacing that we mentioned as well. And then at each of these age points between the permanent molars, we want to see the correlating millimeter distance as well. And with having those numbers, then we can have a good sense of the ability of that human to have enough room for their teeth, and that they also will be breathing properly through their nose. If we look at the direction of growth here, we can see by 2 years, and between 2 and 17 years is where that growth occurs. We're 50% developed by age 2. That's why it's fixed by 6. Let's don't wait till they're 7 years old and have their first set of permanent molars before we're going to do something about this. If by 12 they're average of 90% grown, then we want to get in there sooner rather than later, so that that brain can develop and we can have a healthy, well-adjusted human. That normal growth is wider, it's forward and downward, but it has to have that forward component, not just that downward component, because this is what too much downward growth looks like. If you can see this space where the airway is so thin, like a coffee stirrer, with that downward growth, that a clockwise growth back into the airway, as opposed to this forward and downward growth where we've got a garden hose basically to breathe through. That's what we want to see when we look at these kind of images, so that we can see at least there's room for that human to breathe. This is what too much downward growth looks like. It's that gummy smile, and it takes a lot of work to correct that after it's already happened. And so we know that we want to monitor that kind of growth at different stages, but the earlier that we start, the better. And we have great pediatricians in our area. But what do they think about this? I think that they are bombarded with so many things that this bit of curriculum, perhaps, in their studies is overlooked, even though we know that as we go back to this slide, in 2012, this was researched, but there's so much that they have to do to take care of their little kids who are sick. If we just got to the root cause, maybe there would be less sickness. So here's what we do in my practice. We first, on just about every patient, I want to see a 3D image. This is one slice of the 3D image where you can see that we'd like to have about 10 millimeters right here, 8 to 10. But look, this is the adenoid bump right here. So when we take this image, we can see that the adenoids are taking up too much space. Why does it happen? If this child's not very sick, it's going to happen because there is mouth breathing, and that the nose was intended to filter and humidify the air that comes in to our bodies to nourish our organs, and the mouth was not. And so by taking this image, we can see a lot of things that the ENTs may not have a routine of looking at radiographically first. So, and we can look at so much more, so it's very valuable for us to do this. We can also see if these maxillary sinuses are filled up with gunk, all right? We can have an idea if they're clear, how much airspace there is, if perhaps there needs to be allergy testing first, and if we see a lot of these mucocysts. So that's the first thing that we will do. Here's a slide with a lot of words on it. The purpose of me putting it in is not to read every word, but to say that, yes, an infant all the way through an adult can have their airways positively treated by the right diagnosis and then with the right tools that many of us airway dentists have at our hand. The picture in the lower left, we're going to go through those. Those are the ways that we treat our basic age group of age 3 to 19. And we can talk about adults at another webinar that we'll be hoping to have this summer. So here we go. What does a growth guide do? That was the little blue piece that you saw. Here he's going to put it in his mouth. And by doing this trains the tongue to go up so that we can see nasal breathing. So again, human beings are never intended to breathe through their mouths. This worn at night and sometimes actively during the day will allow our kids to get more into the habit of breathing through their nose. And so this again is a picture of that guide. Sometimes we can substitute this for a pacifier. Sometimes some kids take a couple of months to get used to wearing this and wearing it all night. But even this week, I have had parents to write 3 different success stories about the good things that have happened to their 3, 4, 5-year-olds because of wearing their guide. So that, and of course we saw this little girl not too long ago, but she's had quite a success, and we just get excited about that. So this is for another age group, this is where we often will start. And so if we have a child who has a certain, fits a certain look or measurement of their jaws, if their symptoms are heavy, on the heavy side of showing that they've got sleep disordered breathing, then we'll put in fixed glued in upper and lower expanders. We never want to just do an upper. We always want to do upper and lower, because once you expand the upper, if it's not supported by the bite on the lower, then it's not going to stay and you're going to have relapse. And so we go through 3 months of active turning and then 6 months of holding. So that makes for about 9 or 10 months of treatment, sometimes a year if we have to slow things down or catch the lower up with the upper. So, but about 10 months is what we have. And here we can see a picture of an upper just being put on. You notice how you cannot see much of these bottom teeth right here. But then once we get the lower in and we finish that expansion, then look where we are. And after the expanders come out, myofunctional therapy will have already been taken place, and a removable guide is what we we have a patient use at age 12 because they're going to still be growing. We don't want to put them in a retainer at that point. We want to have them wear an appliance where they can continue that growth, where the myofunctional therapy will support what we've done, and that they can really habituate that tongue position and keeping that tongue in the right spot. Here's a case of a 5-year-old who, quite frankly, had been going to speech therapy for some time at his school, but not making progress. And we identified that he had no spaces between his teeth. He was a sweet, well-behaved child, but he just had speech issues. And so we knew we wanted to address the narrowness. We did. And we, after 3 months of getting him expanded, yes, that his mom, the teachers, could understand him better. And we just think giving his tongue more room to be able to perform that articulation probably made the difference. And you can see here on the slide that the other nice little perk is that he'd been having ear infections, and he quit having those ear infections. So this is a case where, I tell you what, this mom she was a fighter, and she would just she would not accept that her daughter had to get teeth pulled. And she was one of those, like many of you listening, who had been doing her research and trying to find somebody, and she found us through our normal ways of how our educational path, and then some social media, I suppose, brought her to us. And look at that overbite. Well, we call it an overjet, but look at that overbite that she has. And to think that we could widen her jaws and rein in those front teeth and align her bite like we have. If a lot of people think this cannot be done, and you're looking at the fact that it can be. These are specialized brackets. We call them carrier brackets. They are not retractive. They don't have the rubber band that go around the front. That's the big difference with these. And this is why in some cases we would use these carrier brackets along with the expanders. And here you can get sort of an idea about how we've taken the inside of the expander out. We've got the brackets, and look at this. So, I mean, this is awesome. And just a year in a kid's life can make such a difference if we're doing it the right way. If we are allowing the expansion to be our primary goal, and then just align everything else without retracting or pulling anything back. And Mom sent me these pictures, and I just love this. Look at those cheekbones. I mean, this girl, she's got her life's just brilliant now. I'm so excited. This is another case that we did back in 2018. Started with some of the guides, and then continuing with expansion. And this kid's driving now, and I saw him the other month, and he's doing great. Never had to have braces because we started with the right principles and just kept going. So and we also did his frenectomy, so he has more tongue space. That tongue can do the job. He has more tongue movement. So that's something that we always pay attention to at the front end. We make sure that we fold that into the treatment at the appropriate time, and that's different for every individual. His mom was ecstatic because he was so excited he didn't have to have braces, because she had a miserable time as a child with braces. So that's nice to be able to make that happen for these patients, for their children, because we all want something better for our kids than what we went through. We get tons of success stories from parents of all ages. We saw a 4-year-old this week, and we've got a 19-year-old that we're taking care of. So it's really exciting to be able to do this for these kids and parents. Now, this is something that kind of breaks my heart, because this was a parent who was really shamed by a practitioner who simply did not know. And, we can't know what we don't know. And my team has heard me say this so many times, but once we know, we cannot unknow it. This is what cavities look like, from acid coming up through this whole alimentary tract, from the negative back action of maybe snoring, but maybe not snoring, maybe just the inability to get good breaths through, and it just sucks that acid into the mouth. It is not neglect. And so we always want to this is our job, to let parents know. We reach out to clinicians to collaborate with them, but that's something that is a fact. It is not neglect. So I hope that this has been enlightening for you all. To have help somebody breathe easier. That's Ralph Waldo Emerson said that, but it's true every day. We're so excited, and people ask me, "Well, why do you do this?" I could be doing crowns all day long, and I still love doing crowns and do that, in fact, in my life. But my reasons go back a ways. About 1969, my parents gave me a real live baby doll, and my little sister Lori was, I was the firstborn, and straight laced and went to school and all that jazz, and she was the gregarious one. But she passed away in her sleep. And what I didn't know at the time, but found out in 2012 when I started treating adults with sleep apnea, is that she was diagnosed and she never got treatment, not even with a CPAP machine. And so while it's tragic to know that, to remember that, and to relive it, I suppose, and share it with people, it becomes my why. This is the reason. And so if we can help a child before it gets to that point, then to me that's the best thing that I can do to live my journey to its fullest. And so, that's pretty much my story that I want to share with parents. We all know a child, have a child, or love a child. And I want to be the clinician that helps the parents to collaborate with the right provider and things that I may not do myself, because you can't do everything. But hopefully that has enlightened those of you who are kind enough to be here tonight. And Amanda, I'll just turn things back over to you.
All right. Thank you. Let's see. I'm getting a little bit of echo on my end. There we go.
Sounds okay to me.
Okay.
So you know.
Okay. Let me see if I can adjust my volume. So I have a few questions that have come in. One is, what is myofunctional therapy, and does everyone need it?
Well, probably everyone needs it. However, we assess in our comprehensive exam on any new patient their flexibility, the mobility, I should say, of their tongue, because that tongue needs to be able to go work around the mouth and live in the roof of the mouth. So it helps so many people. In fact, we know it even helps snoring in adults. But especially if we need to expand a patient, to keep them expanded for their life, they need to do myofunctional therapy so that their tongue will stay in the right place at the top of their arch.
Great. Another question is, what happens during the evaluation?
So during our evaluation, our comprehensive exam, as I said, we start with a CT, a 3D image of the head. It's a very large field of view so that we can see almost all of the head really at this point. And so I'll actually go through that with the patient or the parent and point out things that I'm noticing about their nose, or if there is any constriction in the airway. We sometimes, well, adults mostly, we look at the TMJ because there are things that we can identify that are specific to a patient who comes in for that. But we look through that. I'll do measurements of the arches. So it's really measuring the upper arch according to the chart that we went through a moment ago. And then we don't measure the lower arch, but we look at the bite. And are those lower teeth tipped in because the tongue is so weak and letting them tip? So those are just some of the things that we do. I'm sure I'm leaving several things out, but it's very comprehensive to really look at the teeth, the gums, and the jaws, and the airway.
Great. And then another question is, do you work with ENTs? When would you refer out?
So depending on the age of the individual, and our treatment modality that's going to suit them best for that age, there are times when we need to refer out to an ENT right away. Most parents don't want to have surgery, and some of them come to me because they've been told that tonsils or adenoids or both need to come out, and they just want to have another viewpoint. And so while I understand that they would want to avoid surgery, the truth is that tonsils and adenoids, if they're swollen enough to occlude the breathing tube, they probably need to come out first. Now, if there are not a lot of symptoms, we may say, okay, the tonsils aren't that big, but they're a little big. Let's go ahead and let's develop the jaws and let's get some habit of nasal breathing. And if they can stop, this child can stop mouth breathing, then we might see those tonsils and adenoids go down in swelling. In fact, we've seen that before. So that's my approach to adenoids and tonsils.
Great. Another question is, my child mouth breathes, snores, wets the bed, grinds their teeth. What do I do first? Who do I see?
Though that's checking off all the boxes of a lot of symptoms. And for that reason, I would, it is beneficial. I've seen the benefit of coming to see us in our practice first. And the reason is tied very closely to that CBCT, that the 3D image. Because if we see that, and the ENTs do not take those images on their patients right away. They may scope down the nose, but not on a 3-year-old. So to get back to the answer, if you come to see us first and we have a CT that then you can take to the ENT, or I have a few on speed dial, I'll shoot them a picture of a screenshot, and they're very receptive. The ones that I like to work with are very receptive that way. And so then it does mean you're coming to see us first, but it doesn't mean we're going to do the first treatment.
Very good. And then another question, maybe this is the last one. What about infants? Who sees them?
I am trained to do an evaluation on an infant, but I don't do the frenectomies on an infant. And that really would be the time, if they're not feeding, if they're not latching, if there's pain there, that's when you need someone who does infant frenectomies, and we've got great referral sources for that.
Great, great. And just to wrap it up, on our website, we have some great links. One would be a preferred provider link with a lot of providers that we collaborate with, infant oral motor providers, as well as ENTs, as well as sleep doctors, and gosh, the list goes on. And then if you're looking for products that would help, we also have a recommended list of products. So that's all I have. Do you have anything else to add?
No, Amanda, thank you so much for organizing this. And, we're honored for you to come listen to us, and we feel like we are making a difference in lives. And so if you're just wondering, then call us and make an appointment, and we will be happy to help.
Great. Yes, definitely reach out. You can reach out straight to our office or through our website, and we would be happy to answer any other questions.
Thank
All right.
you. All
Thanks
right.
for attending today.
Bye-bye.
Bye.